Okay, thanks very much. Thanks for giving your time up to come here on the evening. I know it's so precious and evening, and congrats to Eisen for a great, dense presentation. Eisen really is a world expert in this area, so we're lucky to have him in this area of Sydney. Today I want to talk about men's health, so the flip side of it. Men's health is kind of like a simpler version of women's health, so I'm going to talk about really parallels to what Eisen did in men. So I've really tried to niche down on embolization therapy, prostate and varicocele we'll talk about today, and the arthritis my colleague's going to speak about next, and also involved in treating liver cancer. So look, I think it would probably be a really common scenario for you to see older chaps who have urinary symptoms, straining frequency, nocturia, incomplete emptying. It's all so familiar, LUTs. And these are disabling, like especially nocturia. Poor chaps are up 4 or 5 times at night. They basically get terrible quality of sleep, which means terrible quality of life, and you know, having to plan their trips around toilets, you know, limit fluids like beer and coffee, and it's just a massive impact on older gentlemen's lives and quality of life especially. And you probably know an enlarged prostate is anything over 33 cc's, and it runs the gamut of sizes, and the symptom severity doesn't correlate really with the size. They'll often have tried medications, some herbs or some of the common medical therapies, but still have persistent symptoms or not be happy with their medical therapy because they're lightheaded or develop dry ejaculation or lose their sex drive. So in this scenario, they'll have obviously seen a urologist or maybe two, and the vast majority of chaps I see have probably been offered TURP surgery, but they're scared to death about TURP surgery and they're not really interested in it, or they're young, they're still having a sex life and they don't want to change their ejaculatory function, so they're really hesitant to undergo surgery. And so they're seeking options between medications and surgery. And this whole thing is like a frog in a boiling pot, you know, they just get used to it, they just change their life, adapt, as I said, interrupted sleep. They just don't feel comfortable to do anything about it. These symptoms can be kind of looked at in terms of voiding symptoms, which have an overlay of, with the storage symptoms, there's an overlay of bladder-related dysfunction, increased frequency, nocturia, and urgency representing bladder dysfunction, secondary to chronic obstruction, and then the voiding symptoms itself, which is what we're primarily addressing with improving outflow. And then they have prostate enlargement. So what can we do for these patients, and how do we judge when someone's suitable? Well, it should be affecting their quality of life, which is kind of a prerequisite to do anything interventional. You wouldn't want to do anything more than take a herb or a medication if it's not severe, if it's not moderate or severe symptoms. And then it's recommended that before doing any interventional therapy, whether it's what I do, which is prostate embolization, or a minimally invasive surgical therapy, that they've tried some medical therapy at least, because that's less invasive than medication, than an interventional procedure. And so you're probably familiar with alpha blockers and 5-alpha reductase inhibitors, and these benefit a lot of gentlemen, and you know more about it than I do, I think, as GPs who prescribe that day in, day out. But certainly there's a large number of patients whose symptoms persist despite that, and it can affect their sexual function or cause side effects that they're not happy to accept. So they either stop taking the medication or continue on it, but life still is poor quality. And it's amazing how many patients are offered a TURP and are scared to death of the TURP, or they're at high risk for a TURP, so the surgeon's reluctant to offer them a TURP, they're on anticoagulation, or they're at high surgical anesthetic risk. And depending on which urologist they see, they may or may not be offered this bag of what's called minimally invasive surgical therapies, which includes what we do as you know, endovascular surgical interventional radiologists, but also a few surgical techniques you've probably heard of, like Rezum and UroLift. So if they see a urologist who does these things, they may get offered another minimally invasive treatment, but if they don't, they'll just be offered a TURP, and then they'll go home. They'll either have the TURP, and that's great, and TURP works very, very well, or if they don't, they'll go home unhappy and continue like that for years or decades. So to kind of summarize, if a patient has LUTs affecting their quality of life, an enlarged prostate, anything over 30 or 40 cc's, Medications tried, but no good. And reservations about surgery, we can have a conversation with them as an interventional radiologist, work them up a little bit further if necessary, and then offer them a minimally invasive treatment. And these are the options. It's basically accept life, try the herbs and medications, step up to a minimally invasive treatment, or go the whole hog to surgery, TURP or laser, and rarely prostatectomy. So we'll focus a bit more down on minimally invasive treatments. PAE, UroLift and Rezum. That's what I'll talk about most of the time. This is actually a slide from a presentation I did with a colleague urologist. And this is his slide. What are the downsides of TURP? Well, there's a few days in hospital, the bleeding risk, urinary tract infection risk, sexual dysfunction, a very high incidence, maybe 70% plus of retrograde ejaculation developing post-op, as well as irritative bladder symptoms, urethral stricture, bladder neck contraction, and rarely serious stuff like TURP syndrome or serious bleeding. So in the minimally invasive camp, you have a few options, of which really I'm only an expert in prostate embolization, and I work together with urologists if they're potentially a candidate for the UroLift, a stent, or Rezum or water vapor therapy. But one thing you'll note on the last square of this presentation slides is that prostate volume, all of the lower three options which are offered by the surgeons tap out at 80 cc's. So anything above 80 cc, really at a stretch, recent data, they could stretch Rezum to 100 cc's, but in these large prostates, they can't offer minimally invasive surgical therapy. And when you look at degree of symptom score improvement, prostate artery embolization does better than the other minimally invasive treatment options, and probably has more longevity. And I'll show you a direct comparison, because the data for the minimally invasive surgical therapies outside of prostate embolization is substantially lower quality than TURP. And prostate embolization now has 12 years of data, numerous multi-center randomized controlled trials, and as well as international position statements from NICE and the American Urologic Association. So, when we look at comparing these minimally invasive treatments, like if your patient says, I've heard about UroLift or I've heard about Rezum, and I might have heard about prostate artery embolization after tonight, hopefully, how do we choose? Well, there's an easy choice, which is if it's over 80 cc's, PAE is the only choice. But also if it's 40 or 50 to 80 cc's, they can choose any of these options. If it's a very small prostate, I'll generally revert them to a urologist with a minimally invasive interest, because in prostate embolization, it's a little trickier to get reproducible results in very, very small, just minimally enlarged prostates. So we're generally seeing patients with 40 or 50 cc's and up. But when you compare them, it basically says there's no significant, the significant differences were limited, and the most durable was aquablation and PAE. Now, aquablation isn't even widely available in Australia yet. It's being used in the US, but I'm not aware of any urologists in Australia offering aquablation. So if we look at the stent, the stitch, and the steam therapy, they all have lower quality data than prostate embolization, which we offer. And when you compare at 12 months, the TURP and PAE are right on the same line. So they're doing the same as if they've had a TURP in terms of their prostate symptoms. So what is embolization? We go into the wrist or groin artery via a pinhole, little needle prick, feels like they've had a blood test. They don't even need sedation, but we give them some sedation so the time passes quickly. It's an angiogram-based procedure via a thin catheter. That's basically steered into the arteries of the pelvis, and three-dimensional maps taken, and then we steer a very tiny microcatheter, less than 1 millimeter, right up to the prostate, inside the prostate blood supply, like in this cartoon, and then trickle these little sand-like, what's called microspheres. They're basically tiny sub-millimeter particles that float in with the blood supply and just lodge in the tiny arteries of the prostate, inside the prostate substance itself, and reduce the blood flow dramatically. What does this do? We do it both sides. We do it in any artery that's supplying the prostate substance, so the whole prostate gets treated, and then the whole prostate gets a little bit inflamed, so they get a bit irritation, like as if they've got a UTI in the first week. That's their main recovery-related symptom. But it's a day procedure. They don't need a urinary catheter. They go home the same day. After that week of inflammation, improvements start. and over about 2 or 3 months, by the time they've hit about the 2 to 3 month mark, their symptoms have improved the same as if they had a TURP. Multiple randomized controlled trials say that. So it's been around since the year 2000, initially employed to treat bleeding prostates, but been used since 2010 with hundreds of articles on safety, multiple meta-analysis, and we have long-term data. Now the main thing I think it underperforms TURP in is I think that sometimes people can get very long-lasting results from TURP, and all the minimally invasive treatments I've mentioned, including prostate embolization, last in the range of 5 to 7 years. And probably those other ones I mentioned don't perform quite as well as PAE and the not yet here aquablation in terms of length of time, but it's about 50% of patients who have done well at 5 years might be thinking about a reintervention. 50% might still be happy at 5 years. So that's kind of long-term robustness that they're looking at. So what that's good is that a chap who's sexually active could kick the can down the road for a few years and still be happy. And if they're very old, they can get the symptom response and never need a TURP. And they can always go on and have a TURP. It's unaffected. In fact, it's probably safer because now the prostate's smaller and less vascular. So here's an example of a patient. We use this prostate symptom score with, it's a bit hard to read, but it describes all the symptom domains like urgency, frequency, getting up at night, and higher numbers like 5 is all the time and 0 is not at all. And so this is an example of a patient which would select they've got bad symptoms, doesn't want surgery, and occasionally would need to exclude other things like, it's not a treatment for malignancy, okay? So if someone has an elevated PSA, they should go down the standard urologist pathway, get their MRI or biopsy, make sure that it's not cancer, because this is a benign prostatic hypertrophy treatment, not a treatment for cancer. It's, as I said, day procedure. Generally, very few patients need a urinary catheter. It's light sedation or local only, and there's no pain during the procedure at all. And they just take 48 hours off strenuous exercise, so they're back to work 2 days later, basically. We use this really nice lab that we've got with 3D guidance. There's the new lab, like some people worry about X-ray exposure. There's very, very low risk, the X-ray doses we're using, and they're much lower than in previous generations. And in older patients, this is really an overblown potential risk. So out of more than 3,000 patients, for example, we see a halving of the symptoms. So I say to guys, you're basically going to be halfway back to when you're 20. When you're 20, you had 0 score, it's perfect. And then gradually things creep up and the scores go up. And then a prostate embolization or a TURP will get you halfway back to perfect. So it's going to wind the clock back by 5 or 10 years for you. Quality of life improvement is substantial, and as I said, mostly sustained up to 5 years, at least 50%. And there's an interesting trial that my buddy in Brisbane ran, and basically compares Duodart, which is best medical therapy, versus prostate embolization in a randomized controlled trial. And the improvement in symptoms was more with prostate embolization, almost twice as good improvement compared to Duodart. And sexual function declined with Duodart and improved. We can't hang our hat on that. It might not be significant, but it certainly didn't get worse with prostate embolization, whereas it does for some patients with Duodart. So basically, a patient, if they're doing poorly on Duodart, will do better with prostate embolization. Okay, I'm going to keep moving. The major complication risk is very low. It's about 0.3, so about 3 in 1,000 patients could get a serious infection which requires antibiotics. There's one case of a patient who had a bladder injury in the entire world literature, and that was from South America a decade ago. The main serious risk, which I mentioned to every patient, is there's about a less than 1 in 500 risk of getting some irritation of skin on the penis if some of the microspheres irritate the skin, and occasionally an ulcer, and that's the most serious, severe, but very, very rare thing they could get. They all get some irritation, some dysuria. It feels like they've got a UTI in that week after the procedure, and that's normal. A small chance of a bruise in the groin or a minor infection that we're treating anyway. So anyway, here's an example of my first patient I treated 7 years ago here at the SAN. See the symptoms, they're mostly all on the affected all the time. He saw 2 urologists, but he didn't want a TURP. He was on Flomax for 2 years, and he's severely limiting his fluid intake. He had 111cc prostate, so he couldn't get any other minimally invasive options. So this is an example of a prostate embolization. That CT on the left is what I use for planning the procedure, a beautiful 3D map. And then on the right, that's what I see when I do the procedure, kind of a correlating image where we see the arterial anatomy of the pelvis, and then get super selective down into, this is the prostate, like a half an apple look. And that is the prostate artery here, those two branches. And then these tiny little branches inside the prostate, that's what we're actually blocking. And that's what's going to prevent blood flow from coming back quickly. So that's closed off completely, but inevitably the body finds ways of forming new blood supply. So the prostate doesn't die off completely, it just shrinks down over months to meet its new reduced blood supply. I use this kind of fancy 3D guidance which makes it look nicer and just gets me there quickly sometimes. And this is the guy's response. This is why I started. I mean, his symptoms went from all the time to hardly at all. That's a bit better than the literature would say is median, but that's, it's not rare to get that kind of result. But we can bet on a result where their symptoms get as good as a TURP. So that's prostate embolization for benign prostatic hyperplasia. I'll talk briefly about varicocele, which is that's kind of the equivalent prostate enlargement as the uterine fibroids and adenomyosis that Eisen covered. And then varicocele is the equivalent of the female pelvic congestion that Eisen also talked about. So basically, this is just like varicose veins in the legs, this is a failure of the normal anti-gravity valve systems in our veins that prevent downward pressure from venous blood as we stand up, as we strain or exercise. And what this results in for the male is most commonly a bag of worms of swollen veins around the left testis in the scrotum. This is a very common condition, and basically feels like a bag of worms. That's the classic description. And most of the time it's 90% on the left, 9% bilateral, so rare on the right. If it's only on the right, that should trigger a CT abdomen for an investigation of why has this happened. But on the left, that's classical, and bilateral, that's quite common too. So it affects more than 10% of the population. So that's massive numbers, but most patients are asymptomatic, so it can be simply left alone and ignored if it's not causing trouble. The main symptoms, as you probably know, are that patients can get dull aching pain, similar to the women's issue, or similar to varicose veins in the leg. It's exacerbated when it's an activity or a hot day, standing or straining. Sometimes tight versus loose underwear feels better for the men. But if it's painful left scrotum and they've got a varicocele, then that's the correlate. Abnormal sperm motility is also caused by the heating of the testis abnormally from being surrounded by full veins. It can't drop and cool the way it should. Maybe hypoxia from the venous stasis, because we've got basically venous hypertension affecting this scrotal veins. So they're the clinical issues. They're the only two reasons we would intervene is suboptimal sperm parameters in someone who wants to get have a pregnancy, and pain. And it's a simple confirmation, just an ultrasound, standard testicular ultrasound, which will show dilated veins, more than 3 millimeters of varying distribution. So, at the very first, they just start in the inguinal region during straining, but then they work their way down to eventually be there all the time, with or without Valsalva. And the procedure is very straightforward. It's a half-day procedure. It's not even a day procedure. It's a couple of hours. And they have, it's a low-risk procedure where basically we can enter the neck or leg vein, again like a pinprick, threading a small catheter, it's kind of about the size of a piece of cooked spaghetti. And under X-ray guidance, we're traveling down from the neck, straight through the veins, into that failed left gonadal vein, as per this little diagram here. And normally what we'll see is that the left vein has failed and it's trickling down just like Eisen's picture. And on the male, it's a much simpler version than the female. In the female, you're normally worried about 4 veins, like you talked about. In the male, most of the time, it's just 1 vein, occasionally 2. Very rare to see other patterns. And the simple treatment is to close the vein internally with a microcoil, and additionally use a little bit of what's called sclerosant fiber veins, same stuff you inject into varicose veins to treat them. Here's a recent procedure from, I think it was last week or the week before. A chap with there's the kidney vein. You should not see this vein at all. That vein should be taking blood up from the scrotum. It should not be going down from the kidney into the scrotum. So this is the abnormality is that we see this vein at all. It should be traveling the other direction when I inject dye here. So it goes down and we know it's failed. It's also big, and the guy's got a varicocele. So I can go down to the level, basically just above the inguinal ring, and put 2 coils in. You can put, there's variable numbers of coils, but we put a few coils in, and also use the fibrovein sclerosant to close the vein. They can also have surgery, micro-ligation, basically a small cut, microscopic dissection of the cord and of the vein, and clipping of the vein, and then suturing. This works well. They both work equivalently well, about 90% response rate, with a risk of about 10% of it coming back with both techniques, approximately. But the risks of embolization are significantly lower. It doesn't have some of the serious risks that surgery could occasionally have, like persistent hydrocele from the lymphatic disruption, or the small risk of permanent loss of the testis if the artery is accidentally clipped. These things aren't risks of embolization. Embolization has a small risk of getting pain, pain in the scrotum for the first couple of weeks. And the main serious risk we talk about but rarely see is that it's possible for these coils to move, and then we have to retrieve them and pull them out of the lung essentially, but they normally don't cause any morbidity. That risk is less than 1 in 100, and normally that can be fixed without any morbidity. But overall, most urologists actually, in my experience, refer to an IR to do the embolization procedure. Tell me if I'm running over time, please, David. How am I going?
I will let you know.
Thank you. So most urologists do actually just refer this on for embolization as the first choice treatment. So it's a simple algorithm. You don't necessarily need to refer to a urologist. If there's a varicocele and the patient has symptoms, we can just treat it, because most of the time they'll get referred to us anyway by the urologist. There are a few key urologists in town who are very good at microsurgical ligation and will offer it. And I collaborate with them if it's a difficult case, if it's a case where it's recurrence. We talk to each other and discuss which one would be better. But in the main, most patients can choose tend to like the endovascular option. The recovery is very simple. Can return to work. Well, I said next day. That's not really right. They should have another day off because they got sedated. I like them to avoid strenuous exercise for at least a week so that everything settles in and is bedded in nicely. Most have no pain or mild discomfort. At 3 months, I normally do an ultrasound to check for any persistence of varicocele, and semen analysis could be repeated at 6 months. And pregnancy rates in those patients who are affected in terms of fertility generally go up from about 20% baseline to 50% in the treated population. So take-home points, thanks for listening. I really appreciate your time. I'm treating men's health with a minimally invasive approach. A lot of overlap with urologists. I have a lot of urologists I work with closely, so it's not cowboy stuff. Basically, it's just less invasive, and patients get an option of getting treated when they might otherwise be scared of surgery. So, PAE, they get to keep their ejaculatory function, a little bit better sexual outcome, and symptom control is definitely better than best medical treatment. Same symptom improvement as a TURP, much faster recovery and less risk, no catheter compared to a TURP. Varicocele, they should be offered treatment rather than just sat on if it's causing symptoms or fertility concerns. It's a simple ultrasound diagnosis, and it's a relatively simple procedure, which is generally offered ahead of surgery, but there's a role for both. Okay, so thanks for your time. Really appreciate it.